My paper is on GI bleed, and the chronic problem is liver cirrhosis. My name is Monica Gieske. CP is a 77-year-old married female, lives with her husband, and her eldest daughter takes care of her. She came in with frank blood in the stool, and she was throwing up blood as well. Medical diagnosis is upper GI bleed. Chronic illness is liver cirrhosis, diabetes, portal hypertension. Treatment for the chronic illness is transjugular intrahepatic portosystemic shunt, done 5 years ago. Liver cirrhosis, diagnosed 15 years ago. Nursing diagnosis is deficient fluid volume deficit. Key nursing interventions assess causative precipitating factors, which is the upper GI bleed, evaluate degree of fluid deficit, strictens eyes, nose, hemoglobin of 9.0, corrects and replace the losses to reverse pathophysiological mechanisms, administer 2 units of packed red blood cells and fluids, and promote comfort and safety. Self-care capacity with chronic illness and treatment demands. CP is not able to ambulate. She appears weak with an unsteady gait. Family states CP is usually able to ambulate on her own. Today she's weaker than normal. She's gotten progressively dependent on others for mobility due to her illness trajectory. Intermittent confusion related to the rise in ammonia levels. She has incontinent episodes at night, and she needs help with activities of daily living, such as bathing. The ammonia levels rising is complications from the TIPS procedure that she had. Priority issues, patient issues with discharge planning. Priority issues is to keep the ammonia levels within normal limits, because increased levels of ammonia lead to disorientation. It's going to be important for her to follow up with all her doctor appointments, especially the GI doctor, teach family symptoms of progressive confusion as and when the correct time is to bring her to the hospital, and also refer family for palliative services so CP and primary caretaker daughter can remain comfortable. It's going to be important for CP to continue taking the lactulose. The lactulose is not absorbed from the small intestine, but moves directly to the large intestine, where it is broken down by colonic bacteria into small organic acids that cause production of large loose stools with a low pH. This low pH favors the conversion of ammonia to ammonium ions, which are not absorbed by the blood, and low pH, which is acidic, inhibits intestinal degradation of amino acids, proteins, and blood, which then stay in her system. Clinical judgment about where patient can be discharged. She should be home with home health. CP's primary caretaker does not want her in a long-term care facility or in a skilled nursing facility. And the home health nurse can monitor her blood draws and ammonia levels and make sure that the medication she's taking doesn't interact with the other ones that she's at home with. Priority nurse case management strategy at the patient level, supporting transitions, monitoring physiologic stability, teaching disease and management, and coaching the caregiving for family. System level is team communication and planning and coordinating. It's going to be important to transition CP into palliative care, and the family will need help adjusting to that. They're going to need help with physiologic stability due to her level of ammonia rising at random times, and teaching the family to look for signs and symptoms of confusion and when it's appropriate to bring CP to the hospital. Also coaching the family on how to properly care for CP to ensure the baths are done correctly so the caregivers do not hurt themselves in the process. And on the system level, team communication is important to keep healthcare practitioners aware of her status, planning and coordinating to make sure CP is followed home with home health, and to get palliative referral for her and her family. Intervention for the patient level nurse case management strategy. Refer CP to palliative services and teach family of importance in obtaining comfort care for mother and adult daughter. Lab draws to monitor ammonia levels. Give the family pamphlets to take home and read, and allow time for questions while they're in the hospital to answer any family concerns. Teach bag method on giving baths and incontinence care so CP and caregivers are being taught the body mechanics to decrease the risk of injury. Teach the family that not all palliative care is hospice. so that they are knowledgeable about the difference and will not turn down services thinking that care is aimed towards end-of-life issues. Lab draws will be important to monitor for ammonia levels. Intervention for the system level nurse case management strategy with team communication so that all doctors, nurses, caregivers should have active communication and be aware of CP's care in terms of her hospitalization and ammonia levels, planning and coordinating home with home health and palliative care team referral. Howell and Tahan state that perception is an important strategy for communication. To truly understand another's perception, which is often the cause of the problem or illness, misunderstanding, or behavior, the case manager must listen and determine the perceptions behind the words, must be able to see through that person's eyes. By doing this, the case manager is likely to observe greater compliance because the other person's perceptions and capabilities have been acknowledged and respected. The goal is to get CP and family to agree with palliative care and have team of doctors and communication to ensure a good plan of care. If CP feels that she is being respected and listened to, she in turn will be compliant with the referrals that we give. Utilization review. Due to CP's urgent admitting diagnosis, utilization review necessitates use of hospitalization without patient or family contact. Medical necessity determines that CP requires blood transfusion, therefore is in need of direct medical care. Quality and safety issues. CP obtaining 2 units of packed red blood cells would meet quality issues since her hemoglobin is 9 and she has an active upper GI bleed. We want her hemoglobin not to go any lower than that. As far as safety is concerned, when administering blood, make sure 2 RNs cosign and read labels prior to administering, 2 patient identifying data when providing care, and medication review, comparing CP's current meds with those ordered while under the care of the hospital, so there's no medication interactions. Traditional quality improvement is a process that determines whether the care provided meets medical and nationally recognized and accepted standards. QI activities are designed to monitor, prevent, and correct quality deficiencies. Worst case management effectiveness at patient level. Monitoring physiologic stability with blood administration. We want to ensure patient is monitored properly, vital signs taken every 15 minutes at first, then every 30 minutes, then every hour. Make sure it's the right blood type and cross-match for CP and obtain consent. Assess for signs of reaction and stop the infusion if she's having signs of a reaction. Teaching disease and management. Make sure CP and family can see the admission reason and signs to look for when discharged home. Teach back method for proper biomechanics on how to continue caring for CP at home. Worst case management effectiveness at system level. Make sure CP is transferred from the ED to proper level of care within the hospital system. Make sure appropriate diagnostic tests are ordered to help diagnose CP's issue. Make sure the doctor is aware of the lab result, which is proper communication. Make sure timeliness of referral to home health is made. Ensure adequate interdisciplinary collaboration, an appropriate treatment plan, and goals with home health. And here is a list of my references.